Thank you. I see Columbia folks here. So Ruby was a first resident at Columbia when I was Gen Med ward attending, and I was happy to write her a letter of recommendation, and now she tells me she's finishing her fellowship, which I can now add a couple of more years under my belt in being in GI, and Chris, who goes back to our days at the Brigham. So familiar faces. Thank you for having me today. Thank you for joining this morning. I'm going to do something outside of the box today. I'm going to introduce you to pretty much the latest that's come out with respect to genetic risk assessment. I'm going to focus on colon cancer because the most strides have been made, even in a short window of time in the last 2 to 3 years with genetic risk assessment. So my research career was really on developing prediction models and figuring out who to refer for genetic testing at a time where we really focused on family history, patient's history, tumor testing results. We were still thinking about pre-test risk assessment. And now that the technology has fast forward and genetic testing has become so easy from the lab sense, how quickly the field is moving, and are we up to speed in our clinical interpretation? So I'm going to turn things on their head a little bit, and I'm here for questions afterwards. So hereditary factors, as you all know, play a role in the etiology and risk of colorectal cancer and pancreatic cancer. Germline testing for hereditary syndromes is really an effective tool for cancer prevention. And the technology now with next generation sequencing, not just of the tumors, but genetic testing and clinical genetic testing really provides rapid, simultaneous testing for multiple germline genes. So in our traditional approach, we would look at our patient, the proband, based on their personal history, as well as their family history, some clinical criteria that have been long developed to identify inherited risk. And then we also had tumor testing results. So your pathologist would give you MSI reporting or IHC reporting on your colon cancer tumors. And you would say, I think I figured this out. This is Lynch syndrome, or this is classic FAP or attenuated FAP. And you would order the test for that syndrome you were thinking about. And the beauty about that is that when you identified someone, you could really put into place their screening, their surveillance, subsequent colonoscopies, intervals, extracolonic cancer screening that you would do. You would actually dictate what kind of surgery they potentially would get based on the genetic testing results. You would screen family members, and this is important because if you have a patient with Lynch syndrome or FAP attenuated, you really want to get those family members in. So for one individual that you identify with an inherited cancer risk, you have at least 5 other family members you can target and invite over for increased screening and genetic testing. You have their children, you have their siblings. So you have a really good opportunity of providing genetic testing and cancer prevention to those family members, so extending prevention. And then also reproductive counseling. With assisted reproductive technology, there's also the possibility for pre-implantation genetic testing, and we see an uptake in that for FAP, which is associated with childhood cancers and a really severe phenotype. So we do bring that up in our discussions with genetic evaluation. So through the years, we've gone through the traditional approach. What syndrome is it? Let me test for it. And a lot of genetic testing has been done in the last decade for inherited cancer syndromes. And a lot of questions have come up with the uptake and the increased uptake of genetic testing. How good are we? Do we have the clinical criteria right? Is tumor testing all there is? Should we go straight to genetic testing or still follow this paradigm? And there's a bit of a shift. So today we're going to focus a little bit on the syndrome specific, but really looking at the multi-gene hereditary cancer risk assessment. And for colorectal cancer, we're going to focus in on 3 cohorts where there are really, really strong studies that are going to support what we are now doing and recommending with genetic testing. We're going to look at cohorts related to those individuals who have suspected Lynch syndrome. Lynch syndrome is the most common inherited colorectal cancer syndrome. And the prevalence now, because of all this tumor testing that we were doing on every colorectal cancer that came through the door, is in the order of 1 in 350. So that's very high. That's as high as the prevalence in the general population of BRCA testing. So we need to own this the same way the breast cancer folks are owning BRCA-related cancers and malignancies. We need to own Lynch syndrome a little better. We're going to talk about young-onset colorectal cancer and what is the genetic testing at a population level tell us, what mutations are we finding, and also population-based germline testing. I'm not going to talk about pancreatic cancer because things are still very gray, and there are more questions that come out of there rather than giving you information. I can talk about it afterwards if anybody has specific questions. But syndrome-specific hereditary risk is, as we discussed, you would think about the patient in front of you, their family history, were their criteria met. For the patient with Lynch syndrome, you'd have tumor testing results, and that would guide you. If there was mismatch repair deficiency, MSI instability, you would send them for genetic testing. For those with familial adenomatous polyposis, classic FAP is pretty textbook, but if you had a patient that had cumulative polyps and you were taking out on the order of, greater than 10, greater than 20, you would start thinking about an attenuated form of polyposis. If I put this up, this is a no-brainer. Everybody would identify this as a polyposis case. Greater than 95% of individuals would carry a pathogenic APC gene mutation. Classic polyposis. Medical students get this in every lecture we talk about. If I gave you this family history, if you were doing an endoscopy and diagnosed this woman with a cecal cancer at 58 and elicited this family history with a high burden of colorectal cancer, some endometrial cancer here as well, you would be thinking Lynch syndrome, and you would be ordering germline testing specific to Lynch syndrome. And if your pathologist gave you a report that said that there was loss in MSH2 protein staining and MSH6, or just told you that the tumor was microsatellite unstable, you would again be thinking of Lynch syndrome. Universal guidelines from the multiple GI professional societies that came out in 2014 that said every colorectal cancer should have tumor testing, and that was the effort to screen every colorectal cancer patient for Lynch syndrome. And based on abnormal tumor testing results, you were pretty much checking off a box and saying blood testing for Lynch syndrome. That was in 2014, and since then things have changed really rapidly. So this is what we thought we knew everything related to inherited colorectal cancer syndromes. Amongst the polyposis syndromes, you had FAP, a prevalence in 1 in 7,000, attenuated FAP, which is also related to the MUT-YH gene, very uncommon, 1 in 1,800, and that's those individuals who carry 2 germline mutations. Hematomatous polyposis syndromes, even less likely, and non-polyposis syndromes, Lynch syndrome, where the prevalence is approximately 1 in 300 to 350. And I don't have to tell you this, you guys already know this, but if you identify a germline mutation, the guidelines are very firm in when you start screening and how often you would start screening for colorectal cancer specifically, but also for the extracolonic tumors. And it's not uncommon that people would really look up these tables and pretty much put those patients on a surveillance interval. But multi-gene panel testing has really changed the playing field in genetic testing. Again, the technology has become really fast. There are multiple laboratories at a commercial laboratory now outside of academia that are doing simultaneous gene testing. So you get dozens of genes that are really looked at in parallel, and the costs are falling. So patients look at all this genetic testing available, and they look at it at the low cost of $500 as opposed to $5,000, 6 years ago, and they think they're getting more bang for their buck. And they're not that far off from that mentality. Commercial laboratories are really driving this a lot, so there's a lot of competition, and it's kind of borderline to direct-to-consumer advertising. So I don't know if you have patients that come in and say, hey, I did 23andMe, or tell me a little bit about Ancestry.com. Those testing results are actually kind of fun to look at. A lot of nonsense to interpret, and I really don't promote them. But when it comes to germline testing, there's a lot of information that comes out that could have a real big impact, and learning uncertainties, so to say, that we have to put in order. So again, this dates back to 2014 at the very beginning, and this is for colorectal cancer. There's something similar, a little less complex for colorectal cancer. But nevertheless, this is just for you to get an understanding of all at once, you can order a panel, a multi-gene panel, with these genes listed here, And these are the labs that are offering them, and you could see the overlap of what one lab has to offer with another. So there's a lot out there. There are many different laboratories you can choose from, and it's gotten very cheap. So even if insurance isn't thinking about covering it, patients will potentially cover it on their own out of pocket. And this is an example of how cheap it's gotten. $250 to run a multiple gene panel of at least 32 genes. So patients look at this and they want to know more. So where you might be thinking about your cancer specific, let me just think about colon cancer right now. When you're ordering these multi-gene panels, you're getting a lot of information about breast cancer susceptibility, GYN, a lot of other things. So in my career, where I focused specifically on identifying individuals with high-risk GI malignancies, I'm doing more counseling in breast cancer susceptibility and other genes than I ever thought I would. And is this all good? The jury's out on this. Some colleagues at Fox Chase put out an editorial. Is doing all this genetic testing just because it's out there, and maybe we're feeling insecure sometimes when we're assessing our patient, we're just ordering more rather than funneling it down. Is it reckless or is it relevant? And the take home from this editorial was, well, the more you look, the more you'll find. And where I had focused my original career in research in the pre-test probability and risk assessment, and what are you thinking before you're ordering that test, now I'm doing a lot of, yes, I have to keep that mentality in mind, but I'm really doing a lot more after I get results and after I get a lot of confusing results. So these are a couple of patient populations we're going to focus on specifically to colorectal cancer, since that's what we see most. And the objective of all of these studies was to take results from multi-gene panel tests that were run and see what the prevalence of mutations is in these particular cohorts. So we're going to take a look first at the patient population were those that were at increased risk of colorectal cancer based on their personal history or based on family history. So this was done at the Dana-Farber. Over 1,200 individuals had been referred for genetic testing and had undergone genetic testing at Myriad Genetics Laboratories with a multi-gene panel test. They themselves had personal history of a Lynch syndrome-associated cancer, mostly colorectal cancer, polyps in there, but also endometrial cancer. And every individual in this cohort had a multi-gene panel test run through Myriad. So how many of you ordered genetic testing here? Okay. So Myriad has this one-size-fits-all panel, 25 genes. This is what you get. You get your Lynch syndrome genes here. You get your hematomatous polyposis and your APC gene here. The pink are genes not known to be linked to colorectal cancer. So you're going to get BRCA results. You're going to get hereditary gastric cancer results, multiple melanoma, melanoma-related results, and then some moderate penetrance genes predominantly overlapping with GYN and breast cancer. So this is the one-size-fits-all panel at Myriad Genetics. And what they found in this cohort when they were suspecting Lynch syndrome was that 14% had at least one abnormality, the majority of which were in a Lynch syndrome gene. But then there was a substantial amount of individuals who tested positive for something else. So when you're taking these individuals and you're thinking colon cancer susceptibility genes, what else are you finding? The majority, again, were Lynch syndrome, but this is a significant part of the pie. 37% had some other gene, that was on that cancer panel and overlaps potentially with colorectal cancer, we'll see, but definitely with other malignancies of which there is screening for. So let's take this smaller part of the pie and see what the breakdown was. When we look at the other high penetrant genes, we luckily in this cohort enriched with colorectal cancer picked out APC and MUT-YH mutation carriers. There were also a lot of monoallelic MUT-YH. So this is the gene MYH associated with attenuated polyposis. When you inherit two genes, you have a higher risk of colorectal cancer, which comes close to APC attenuated polyposis. But there was a substantial amount of individuals who inherited one MUT-YH mutation. This is still important because our recommendations for these individuals when we get these results are to screen them the way we would as if they had a first-degree relative with colorectal cancer. So you would be starting at age 40 or 10 years younger than the youngest. You would be repeating every 5 years. So this is not insignificant. We do change our screening recommendations based on this result. And then there were a lot of other surprises. So 21% of this cohort had pathogenic mutations in BRCA. These were individuals that were presenting with colorectal cancer. So I don't know if you get the question of, should we be doing something different with colorectal cancer screening in our patients with BRCA, or is colorectal cancer part of the BRCA spectrum? The answer to that was always no, but I think we're going to be looking at the risk estimates a little differently based on the results that are coming up. And then there was a fair amount of individuals that had moderate penetrance genes, genes that we're going to review at the end of this. What are we doing with? What do we know about them? And how does that affect what we're doing with respect to our colon cancer screening and surveillance? No, complete sequencing. A lot of information. That's a good question. MUT-YH used to be hotspots. Now it's complete sequencing, so you don't have to go back and reorder. So the beauty of this is you wouldn't necessarily be looking at BRCA and looking at multi-site, let's say for Ashkenazi Jewish founder mutations. You would be getting the whole gene sequenced out. So it's a one and done deal. It's very complete. So 34% of these individuals who were thought to have Lynch, and these are smart folks at the Dana-Farber who were really screening them based on clinical criteria, weren't expecting to get these mutations. And this is another presentation, but overall the summary, if we were to look at high penetrance genes, and high penetrance is that you're recommending intensified screening, you're recommending in Lynch syndrome prophylactic hysterectomy and oophorectomy. In BRCA, you're talking about risk-reducing surgeries. And because you're the one up front that they're seeing for colorectal cancer, because a lot of them had colorectal cancer, there are also going to be questions related extent of surgery with colectomies and increased surveillance, okay? And overall, 75% of all those tested for an inherited colon cancer susceptibility gene had a pathogenic mutation. So this was the unexpected. And this is where my practice has changed, is that I'm picking up a lot of patients with non-GI related malignancies and having to counsel them. So 1.2% of the overall cohort had BRCA mutations. That's in parallel to APC. The majority of them filled Lynch syndrome criteria, but they did not fill BRCA related criteria. The majority had colon cancer, none had breast cancer, and a small amount had ovarian cancer. So colon cancer was their sentinel tumor. We've never looked at germline testing and risk assessment in other non-GI related cancers as the sentinel tumor. In Lynch syndrome, we got it out of our comfort zone by thinking of endometrial cancer as a sentinel. But now we're seeing in our colon cancer patients, and I think we're going to need to expand in how we do our risk assessment pre-endoscopy, not just limiting to a family history of colorectal cancer. But they did have a family history of breast and ovarian cancer, so that you might be picking up and saying, okay, I should extend my evaluation for more than Lynch. So a couple of new things that came out of this. We do get full sequencing, but we also get variants of uncertain significance. So the more you test and the more deeply that you look into the gene, you're getting a lot of variants that aren't deemed to be pathogenic or benign. So all of these laboratories, commercial laboratories, are giving results in the order of 30 to 35% are giving back results of uncertain significance. So you might get a mutation in Lynch syndrome, or let's say an APC mutation, and it says that it's a variant of uncertain significance, and they're clinically deemed non-actionable. You really do need to go back and look at that family history and draw an extensive pedigree to make decisions related to the surveillance. Because the labs at that point put their hands up and say, well, we really don't know yet, and we'll let you know. And the order of reclassification of these variants can take years. So you really want to be vigilant if you get a result like that, that you're not saying, okay, I'm not doing anything about it. If the family history is very striking, you're not going to ignore it. And then there's the question of these moderate penetrance genes that we'll talk about at the very end. Now I'm going to move over to a cohort which looks like population-based screening. So this group, the same group that the Dana-Farber took every patient, all comers, every individual diagnosed with colorectal cancer. They weren't selected based on their age. They weren't selected based on their family history. They were not selected based on tumor testing results. It was every consecutive patient that walked through the door that got multi-gene panel testing had a personal diagnosis of colorectal cancer. The same panel of 25 genes through Myriad Genetics, and they found about 10% had at least one germline mutation, the majority of which, 3%, was Lynch syndrome, and then we got other genes, so to say. So within these high penetrant mutations, it's not just Lynch syndrome, but other high penetrance genes which will break up. And then there were also moderate penetrance genes. We're not that far off, okay? So the percentages here are near equal. So we're going to need to really pick up the pace in what we're saying with some of these moderate penetrance genes as they relate to GI malignancies. The breast cancer field, GYN, is moving really rapidly. So in GI, we're going to need to come up with some guidelines relatively quickly because this affects how we recommend colon cancer screening and surveillance. So we can't ignore this information. And now a lot of patients come in and say, hey, by the way, my GYN ordered this multi-gene panel test and told me to share this with you. When do I get my next colonoscopy? That's how it's presenting now. So I have colleagues that are emailing me and saying, can you look over these genetic testing results and when do I have to bring her next? And it really does require a discussion. So where I was doing genetic counseling up front based on personal and family history, now I'm doing it at the tail end when patients are coming in with genetic testing results. So this is a complicated slide. It really is the breakdown of what other genes are there. And here you have it again, BRCA in every newly diagnosed colorectal cancer is coming up positive. It's coming up more frequent than our APC and attenuated polyposis genes. So it's something that we're going to have to really deal with. These genes here, PALB2, again, mostly related with breast cancer, but also overlap with pancreatic cancer. This is a melanoma-related gene, and leaf remaining very low as far as the other high penetrance genes, but these moderate penetrance genes are going to be the culprit for us. So the last study we'll review is young-onset colorectal cancer. So this group in Ohio State really has done tremendous work. There was a huge initiative and a lot of funding at a state level where every colorectal cancer patient in the state of Ohio had tumor testing. They weren't selected. Every patient had tumor testing. So if you're going to do tumor testing on the colorectal cancers unselected, you really have a true population base to get information related to Lynch syndrome, but they were also banking their blood. So they took it one step further. In the cohort that they have, and they can do all colorectal cancers and do multi-gene panel testing, but it was expensive at the time, they decided to just focus on those individuals less than 50. If they took all colorectal cancers in the state of Ohio that had enrolled through this initiative and did multi-gene panel testing, what were they finding? So they had 450 individuals that were diagnosed before age 50. All of that had tumor testing result, and they did another multi-gene panel test. So 16% carried a pathogenic mutation. So in young patients, it's worthwhile to do multi-gene panel testing. The majority of which had genes linked to colorectal cancer. Lynch syndrome was most prevalent. You had polyposis genes related here. These low moderate penetrance genes were really important. I selected 2 to focus on here only because the recommendations and because they're highly prevalent. So it's not going to be an uncommon result that you get. APC I1307K is a polymorphism, highly prevalent amongst Ashkenazi Jews. Okay, so if you're screening a lot of Ashkenazi Jews and doing germline testing, you're going to get this result. Monoallelic MUT-YH, as we spoke about earlier, the recommendations for these 2 genes are similar to what we recommend for having a first-degree relative with colorectal cancer, okay? 3% had genes that were not linked to colorectal cancer. BRCA, again, was high. And then you had 33% that if you really stuck to the criteria, the clinical criteria that exists and currently is guiding what we do, so your Amsterdam criteria, polyp counts, you're really going to miss 33% of them. So that's not insignificant. So where we initially were thinking about, my animation is a little off with this, of colorectal cancer syndromes as non-polyposis, predominantly Lynch, adenomatous polyposis, APC and MUIH, and then our hematomatous, it gets a little more complicated. We have a lot of overlap now with these multi-gene panel tests that are coming out with a number of genes, some of which we can guide in screening and surveillance, particularly to colorectal cancer, but a lot that's still in a gray area, and we're going to need some guidance and risk estimates soon. I'm just going to focus on these genes that are not uncommon and for which there is growing evidence currently, and you'll see it kind of come into guidelines. I think the GI professional societies are going to be putting a task force again into interpreting these results. 2014 was when they came out with the guidelines for Lynch syndrome, and because the technology is giving us so much information now with sequencing, those results are going to need to be redone, and bigger tables are going to need to be drawn. So moderate penetrance genes, we talked about APC and MUIH. The other two are CHEK2. This is a breast cancer susceptibility gene. So for every woman, young onset breast cancer patient that had undergone genetic testing for BRCA and tested negative, now there's a recall in all those women that were young onset breast cancers to doing multi-gene panel tests. So we're picking a lot of new breast cancer susceptibility genes, and CHEK2 is breast and colorectal cancer. So this is going to be in our practice guidelines, and we'll talk about the recommendations for now. And these are rare genes, but they're highly penetrant genes. So when they took the cohorts of all the classic polyposis cases or attenuated polyposis, but really striking, and those people who tested negative for APC and MUIH, they picked up a couple of other genes. They're rare. You're not going to see them, but when you do find them, you really have to treat them like a classic polyposis case. We already discussed APC 1307. CHEK2 for right now is also in the screen them as you would if they had a first-degree relative with colorectal cancer. And these individuals are the highly penetrant ones where you would be screening intensively, if not recommending prophylactic colectomy. So in summary, when to consider multi-gene panel testing. If the clinical criteria supports an inherited cancer syndrome, by all means, do genetic testing. Again, adenomatous polyposis, a high burden of polyps in an individual, genetic testing. When there is a suspicion of hereditary cancer because they have just too much cancer in the family and there's not particularly one clear-cut syndrome, but you're seeing breast and ovarian and colorectal and other GI malignancies to go for it. And a second-line testing when the first isn't. So if you're doing that stepwise approach of test for Lynch first and it comes back negative, if you're going to do genetic testing afterwards, do a multi-gene panel test because things are overlapping too much. So multi-gene panel tests, and these tests are here to stay. So they're not going anywhere. They're going to get bigger. Right now, they were too big and some of us want to funnel them down, and that's not happening. They're being ordered a la carte now. So if you want to add stuff because you don't want to interpret too much information, you can. But the interpretation of these results is mostly happening post hoc, after they've had that genetic testing. And again, the goal really is of a lot of these commercial laboratories to go to direct to consumer. So I put up that slide, one company, $250, very inexpensive. For them, the patient goes online, gets genetic counseling through a video, and then has a provider sign off on it. And you don't have to provide a blood sample. You could actually provide a saliva sample. So I think we're going to be getting a lot of these results. And even though I don't want to talk about the medical legal implications about them, there needs to be some know-how on our part of how to make the associations, particularly with inherited colon cancer and these lesser susceptibility. And don't ever fall short of finding a genetic counselor who could help put these recommendations in order for you, or someone who really is looking at the latest and the greatest in the field. What is happening also, and I want to focus your attention, is unaffecteds. So where we're seeing a real uptake in genetic testing are those people who don't have cancer. So forget the proband. It's all healthy people who don't have cancer, who have a family history, and they can't piece it together, and nobody has pieced it together, and really want to do these broad panels because they just want to know. I want to know. And there is a generational gap to this approach. I would say those that are less than 50 really want to know. So they're coming in and saying, I want the bigger, better panel. And my patients who we test, and then we're like, where is this gene coming from? And we're going to older generations. You have a lot of resistance of genetic testing in the 70-year-olds, greater than 65-year-olds. And the in-between are the ones that are actually thinking about it and saying, wait a second, do I really need to do this? And that cohort is probably the one that would benefit the most from some of these screening strategies, because they're in the age group where if you really put in the right colorectal cancer screening interventions and all the other cancer prevention modalities, you might be getting more of a prevention than the really young and then the really old who didn't manifest with the disease. That's where we're at. This is the state of affairs. It's the last of my talk, so there are plenty of questions.
What are the implications for this of insurance companies profiling people based on these results to eliminate certain conditions from their coverage?
Sure. So, there's federal law. It's called GINA. There's a protection that you are not kicked out of insurance. So you can't be dropped based on this result. Also employment. So it's a federal law. There's no discrimination based on genetic testing results. Where there is discrimination, and where I counsel patients, particularly the young, is if you don't have life insurance and disability insurance, you can be ineligible for that. And that's very real for the younger cohort that hasn't thought about life insurance. So there are times where we do this anonymously, or they put their plans in order, and then we do the genetic testing. But based on health insurance, it's a little bit of the train has left the station. If they're thinking of being high risk and you're doing colonoscopy more frequently, that'll get flagged. So it doesn't necessarily impact their overall implications once they have a positive result, because they're going to need that intensified. Absolutely not. There's law. There's federal law. I mean, a lot of things happen in Washington, but for right now, it's protected. Yes.
Are there any data on testing interval colon cancers as far as prevalence and experience?
So that's interesting. They've never gone back. None of the cohorts right now with multi-gene panel tests have done that. That's a good question, because we've always been stuck on the tumor testing. So there is work at looking at the interval cancers, particularly right-sided cancers, and having a different biology and doing full tumor sequencing on that specimen. And it's not coming up so much with germline. So the thought is more on the serrated polyposis pathway, but not on germline. So this is everything I presented right now is germline testing. I think another area, and to speak to your point, is next generation sequencing, at least in academic centers. The goal is that every tumor is going to have next generation sequencing results, because the oncologists want that information for personalizing cancer care. So, Memorial is already doing their impact gene on the tumors. So we're going to be getting information about potential germline alterations from the tumor results. So that's going to be our kind of genetic testing through the back door, where we're going to get results from that tumor, and people are going to be scratching their heads and saying, is this real or not? And then we're going to be doing germline testing and getting a lot of mutation carriers of the cancer cohort that way. That's a great question.
So is that still a role when you have a patient who comes with a family history of colon cancer, pancreas cancer? Is there still a role for testing the family member, or if the family member's tumor is available, and identifying a
So if I got your question right, our traditional approach back 3 years ago, 4 years ago, was look at the tumor. Is the tumor showing us features? We'll talk about Lynch syndrome specifically, right? And then go that approach. Tumor testing is more expensive than multi-gene panel testing now. So IHC testing.
More specific information potentially
from next generation tumor sequencing, yes, but it's not standard of care yet. So on the broader level, I think we're kind of spoiled at academic institutions that have the potential to do it, but on a population level, that's not being done. I think down the line, the more uptake in next generation sequencing of the tumor will be going backwards in that particular cohort. But I think in individuals with a prior history, we're not going to be going back to the tumor. We're going to be doing germline testing. And I think if you were to do a cost effectiveness analysis on how to best identify mutation carriers, it'll be more cost effective to go down these multi-gene panel tests. A lot of the genes that they're picking up on next generation sequencing might be related to, let's say BRCA, but it might be methylation and not necessarily germline. So this is where you're going to need to be teasing it out and funneling it out as to what germline you're going to be looking for. So the literature mostly has come out of the breast cancer cohorts. I think for you have to realize breast cancer, because of its increased prevalence in the general population, there's a need to know, right, because of screening modalities. The psychological consequences in the breast cancer cohorts are really these moderate penetrance genes and the variants of uncertain significance. So those are the downstream consequences where we don't know how to counsel a patient because we don't know clear-cut risks or the surveillance intervals. So testing for them and then saying, well, the jury's still out, we don't know, is really on the order of, psychological distress in the breast cancer cohort. I think it's not going to be any different with the GI malignancies. The one that I worry about that we didn't talk about is CDH1, so that's hereditary gastric cancer. A germline mutation in that now, because they took all these women with young onset breast cancer, lobular breast cancer is related to CDH1. So if those women had been just selected for BRCA testing, now they're getting these multi-gene panel tests and we're getting CDH1. So I get patients coming in with no family history of gastric cancer, and they have an abnormal gene in a condition where we're recommending prophylactic gastrectomy based on the presence of this gene. So that. If you wanted to look at a cohort for psychological distress, I get distressed in screening these patients because the majority of them say, I'm not signing up for anything like this. There's no family history of gastric cancer. And they might be right. I think what's going to ultimately come out of that cohort is going to be a CDH1B breast phenotype and a G gastric phenotype. And then we're going to need to look at other modifier genes. Where I'm turning things on their head, but I don't be surprised if someone comes in and pulls out of their bag, oh, I had this genetic testing and it's not Ancestry.com anymore. It used to be cute. It's going to be one of these multi-gene panel tests that they, provided a saliva sample for.
Sorry, what's the incidence of
The incidence based on a typical high-risk family, so there was ascertainment bias. So these patients were followed at the Hutch, and there was large cohorts, ascertainment bias, so it was up to 80%, where it was autosomal dominant, young onset of gastric cancer. So if family members had a positive mutation in the absence of early gastric cancer, prophylactically they would get a gastrectomy. So now the estimates have been deemed to be lower because the phenotype is not as penetrant as those patients because there was ascertainment bias. Those really strong families were going to a single institution being recruited and the estimates came from there. So it's lower, and it's going to be even lower yet The question is, how are we going to be selecting those patients that would need to go for anything risk reducing? And we're doing more because of the increase in CDH1 mutation carriers. We're doing more as far as gastric screening to looking for signet cells, but it's a lot of biopsies and you're frequently bringing them in. It's a difficult discussion.
We still have time to
Okay.